Hi, my name is Brian Stolte. I am welcoming you here to the Breaking Down Barriers podcast. Our episode today is about substance use disorder. The reason I got to be asked to be the moderator of our conversation today is that I am a director of mission integration and community health at Sierra Nevada Memorial Hospital. So I get to work with the substance use navigators at our hospital, and it's something that I get to witness the good work that's being done in our community. So I come here as a fan of the work that you all do, and also as a supporter. And so I hope to be able to facilitate great conversation with us today. So thanks for having me here. Can we go around and introduce ourselves?
Sure, absolutely. My name's Micah Berry. I'm an orthopedic surgeon up here locally. The reason I was asked to be involved in this is because I'm fortunate enough to be involved in recovery. I have a history of substance use disorder. I've been clean for multiple years, and I'm actively involved in 12-step programs.
My name is Annie Giles. I am a paramedic on our ambulance here in Nevada County. For the last 15 years, I've witnessed a lot of substance abuse in that capacity. I also am the mother of a 20-year-old son who is currently in recovery for opiate abuse. So I'm navigating that side and in Al-Anon now and watching him go through his recovery.
My name is Bethany Wilkins. I have been in various stages of recovery for over 10 years now. Former IV opiate user, and currently I co-founded the Yuba Harm Reduction Collective in 2020, and currently I'm the director of that program.
My name is Christine Norwood, and I work at Sierra Nevada Memorial Hospital here in Nevada County. I'm a social worker and a son or substance use navigator. I have family members who struggle with substance use disorders, but personally and professionally, I just have a thing about social justice. So, yeah.
Thank you, everybody. So one of the things that we always like to focus on in this work is removing stigma, right? And stigma is best removed through understanding. When we understand, when we know people's first names, when we know their stories, we can walk in a little more empathy and compassion. So for those listening, they may not be as familiar with what we're talking about today. Can you help kind of give a frame of reference for how people typically find themselves in a substance use situation where it gets to be a problem? And I know that there's countless ways, I'm sure, but what are some typical ways that you've experienced where people find themselves in this?
In what I've witnessed, and from the personal experiences now with my son, I think there's countless ways, like you said. I think mental health can definitely play a huge part in that. Feelings of hopelessness, depression, self-medicating, anxiety. Obviously, there's situational things, and I think for the youngsters, the kids, that peer pressure, desire to fit in. Also through injury, being prescribed opiates for injuries. I think that can definitely be a starting point.
I think from my perspective, I have both a personal perspective from my own history of recovery. I also come from a multi-generational family of addiction. I mean, my sister overdosed 2 years ago, and I'm still, recovering from that loss. So I have a lot of personal skin in the game, so to speak. But additionally, I also have a professional perspective where I look at substance use disorder. You know, this is something that's been looked at from the American Medical Association as a disease since the 1950s. So we in the medical profession have known that there is a disease model. And we're talking about breaking down barriers and stigmas associated with it. I think one of the greatest barriers that we see is that some people see this as some sort of moral deficiency or a moral dilemma. And I think that there needs to be a lot more research done in the addiction field in general to help establish the disease model of addiction. For example, we look at breast cancer, right? There's been tons and tons of research on breast cancer, and we've made so many huge strides on it. I mean, there is the Komen Foundation, and there is billions of dollars going into research in breast cancer. And I think that's as a result of so many women getting together and basically demanding, you know, research and progress being made in this field. And you know, we've seen marches in Washington, and we've seen the number of dollars for research go up for this. Last year, there was about 50,000 people who died from breast cancer. Yet, when we look at what's happening in the addiction, there was over 100,000 people who died of fentanyl overdose alone last year. So that's twice as many people. And what we see when we look at the research dollars being spent on addiction medicine versus breast cancer research, it is so absolutely skewed. If we spent 1/5 of the money towards addiction and kind of breaking down those barriers, I think we'd make great strides, because I think that there is absolutely a genetic component. Annie was talking about some of the things that expose people to addiction. One is your genetic makeup. We know that there's absolute genetic component to this. In addition, we need to have exposure, right? Because if there's not exposure to the substance, then we don't actually develop the addiction. So, you know, people get exposed to it in different ways. Yeah, maybe from, you know, overprescribing pain medications, maybe from your peer group, maybe from your family. We see that so much as a multi-generational perspective, that it's in your family. You grow up in that environment. But exposure is huge. Genetics play a huge role. And as we uncover and unlock more of those sort of mysteries of addiction, I think that we're going to have a lot more progress made in the field.
Yeah.
So to segue off of that, so basically what you're saying, it is so huge genetically wise, epigenetics, trauma. I mean, research wise, they're saying, you know, 75% of folks who struggle with addiction, there's trauma going on. It doesn't mean someone's been assaulted. It could be anything, an injury, loss, whatever. But it made me think about how what I see talking with families and folks at bedside patients, that it will skip generations as well. You know, people will try so hard saying, you know, oh, well, my parents, they didn't use, there were nothing. There wasn't even alcohol in my house. And I'm like, what about your grandparents? What about your cousin and your siblings? But I think partially what came up for me and what I have seen, it seems like the collective, not just in, you know, our community, but nationally, internationally, is stigma just with substance use. And it's so weird inside of that, because there are folks who think, oh my gosh, if anybody uses anything, they're at a risk for addiction. There are people who use substances. There are people who try different things. Addiction is not going to happen for everyone, but within both sides of that world, the stigma part is, like you said, character flaw. It's not a character flaw. This isn't about self-control. Talking with people so many times, it's all about when someone does have an issue where maybe substance use is impacting their life negatively, and they're thinking, or someone else has suggested they've got some kind of a substance use disorder, but trying to be perfect, you know, trying to be perfect. And people just, you know, basically flagellating themselves like, oh, if only this, if only I could do this perfect. And it's just kind of interesting, the judgment about opiate use versus alcohol use versus, you know, maybe benzo use, whatever people medicate with. Because I'm always like, it's food. It could be cheesecake. It could be porn. It could be video games. It could be bad relationship. I'm like, it's just addiction du jour. And I think helping the mainstream kind of see that, so much stuff has been lionized or, made very negative in some parts of social media. Maybe that a lot more mainstream folks would do, and maybe with some religious background as well, and others looking at it like, oh, well, nobody should be using anything. It's like, that's just not reality, because again, it could be literally they overeat. They are addicted to that relationship. So I kind of think with trying to work on that stigma is to show everybody that it's everybody.
That's
It's
right.
all of us. It isn't those people,
That's
because I'll see that at bedside too, and I'm like, oh, so you're saying your 82-year-old grandma? You know what I mean? And they're like, well, she doesn't want to be called an addict. I'm like, well, nobody does, and we're not saying that.
Right.
Or they'll see something on television, for people who still watch TV, like, well, they're saying I'm an addict. I can't even take that. I'm like, you just had a major surgery.
Right.
There's nothing wrong with that substance. It's some folks are going to struggle with an addiction piece, And so it's really interesting to just kind of watch stigma world come in, go out,
Right.
come in. And it is up to all of us with personal experience, and then not to really kind of check that,
That's right.
because stigma is just not okay.
No.
And it blocks people from getting the help for whatever substance that they're using to, change how they feel or self-medicate. And so anyways, that's my soapbox.
I think it's really important what you said. Sorry,
No,
I
you're
didn't
okay.
cut you off, about it being all of us.
Mm-hmm.
None of us are immune to this. I feel like I was an exceptional parent to my son.
Yeah.
I was there for everything. Love him with all of my heart.
Mm-hmm.
He was a all-star. Never, ever, ever, ever would have expected it. And I've been exposed. I know it's there. I know it's around. I grew up in this county. But it can affect every one of us. None of us are immune to it.
Mm-hmm.
And it doesn't. My kid is an amazing human being,
Mm-hmm.
and he's an addict.
And what's interesting, I'm sorry, I'm going to tell this little story. I went to the substance use disorder convention in Long Beach last year. I don't know, it doesn't matter. And this dad got up there, and he'd started this nonprofit because his son struggled with substance use disorder. And he goes, we lived in a nice neighborhood. We did all the things. He goes, we loved the stuffing out of that kid. And he goes, we would see, he said his son suffered so much with shame, and he goes, yeah. And I can't remember the agency's name or the nonprofit, but he told the story. He goes, we had other friends down the street that had a family member, a kid with cancer. He goes, the casseroles, the whatever, the outreach of the community to that family. And he goes, and there were crickets, nothing to our family. He goes, we couldn't come out to say our family is struggling too. We hurt too, and so, yeah, it's everyone. And definitely there just can't be one worse than the other. Hurt is hurt,
That's right.
so.
Yeah, I agree. No, don't say sorry. I'm kind of backing up a little bit now, but when we're talking about prevalence of substance use or why someone might be using substances, I think it's really important to also acknowledge people from marginalized communities and different socioeconomic backgrounds that have inequitable access to healthcare, to food, to security, to safety, to housing, and these ways that maybe their substance use is self-medication for a mental illness or for a physical condition, pain management, or maybe substance use is a way to cope with intergenerational trauma, which we've kind of touched on, and systemic racism and these different forms of oppression that we've seen actually, and the science behind it, does genetically, affect people throughout generations. Trauma does. And so I think I'm from rural Appalachia on the East Coast in the mountains, and I lived in a very small mountain town that was just ravaged by the first wave of all of this with oxycodone. That's how I became addicted initially. And my community was impoverished. We were poor. I grew up in a trailer, and there's these ways in which it was more normal to be using than not, because it's what's around you and what you're seeing your family and your friends and everyone else use to kind of feel better, self-medicate, and that's just one subsection of it. But I think there's something to be said about people just that already have a systemic lack of access, equitable access to resources that other people have inherently. So
I think that's a good point. We know that addiction affects approximately 10% of the population, right? Somewhere in that range. And it does cross all socioeconomic statuses, right? And all genders and all races and ethnicities. It crosses all of those boundaries. I mean, I've been educated at some of the most elite institutions in the world, right? I'm a graduate of Harvard for medical school. I did dual fellowships at Stanford. I mean, I've been very well trained, and I've been fortunate enough to be a part of these things. But also, I have a really aggressive form of substance use disorder. I still have that, despite my educational background, despite my multiple degrees, despite, you know, all of these things. It still crosses those things. Yet, when you're disadvantaged for multiple reasons, the risk is even higher.
Right.
You know, I have all of these advantages, yet it still affected me. And when you have so many other disadvantages, you know, I think there's just a sense of maladaptive coping mechanisms, because you just don't have the tools when you're at some of these extreme disadvantages.
Yes.
And so then it becomes such a more prevalent thing. That 10%, you know, number that I quoted is probably even higher in your hometown of Appalachia, because of all of those other disadvantages you were talking about.
Absolutely.
Wow, this is really rich. The conversation, it's so much wisdom here. And as I was listening to you guys unpack that a little bit, you know, I hope those that are listening along with me can identify that there is no them in this. It's just us. It's all of us. This impacts all of us. And it's not just the person with the disorder either. You know, the family, friends, different agencies, you know, who all's impacted, would you say, by what we deal with? Am I leaving somebody off? on
Everyone,
this?
unless they're in the dark about it.
Right.
They can ignore it, but I think everyone's impacted. We're all impacted
unless
in
your
one way or
head's
another.
in the sand, then yeah. Thank you so much for sharing that. And it's enlightening. It's sad, but it's also beautiful to hear the contrast between what you're describing as essentially a life of privilege, right? And then coming from such an impoverished place. And substance use disorder touches the whole spectrum. And there's no respecter of persons here. It's just we're all impacted. So thank you for being so open about these things. So you started Yuba Harm Reduction.
Yes.
I would love for the listeners to be able to hear, what is harm reduction?
I always almost struggle with this question just because it's so multifaceted. When I'm, you know, teaching students about it or younger people, I start with the analogy of harm reduction in everyday life can be practices of reducing harm associated with things that humans enjoy doing or are going to do. Examples can be seatbelts in a car that can prevent risk of fatality if someone does crash. Condoms, you know, prevention of STI and pregnancy. Filters on cigarettes, you know, doctors thought it was okay to just totally smoke tobacco raw, and then they were like, oh, this is deadly. Let's put a filter on here. So these are tools to like introduce you to the idea of there's something that humans are going to do, like have sex, drive a car, maybe partake in tobacco, and what can we do to mitigate the risks and harms associated with these things? So when you're talking about harm reduction in the lens of drug use, we're talking about exactly that, reducing the harms and the risks that accompany substance use, the inherent, you know, harms that accompany substance use. And so harm reduction to me is really a radical approach to substance use. I was raised with DARE education, you know, just say no. I think we all probably remember that. You know, and bless their hearts, they had great intentions. But me and about half my graduating class are a testament to that not really working as well as they hoped. And a study done in 1994, actually, they really dove deep into that and proved that it was really not as efficient with preventing teen drug use. Anyway, all of that to say, I look at harm harm reduction is an alternative to that kind of fear and shame-based drug education and approach to drug use that was like, if you do drugs, you're a bad person. You're going to end up on the streets. You are gross, dirty, not inherently worthy of respect and love. And within that model, it just further perpetuates shame, which led me to hide my drug use. I didn't have compassionate people to go to that would look at me and say, like, even though you're using drugs, I love you. You're inherently worthy of treatment, of a conversation, even to talk about this right now. You're worthy of someone listening to you. So I didn't have that. And when you're instead isolated and just told that you're a horrible person for your drug use, you just keep using, because it was one of the only things that actually still felt good when everyone else is telling you, that you're worthless. So I look at harm reduction as a way to support people that are using drugs and staying alive. Like my goal is, within the work that I do, within harm reduction as a practice to me personally as an ethos, is how can I ensure that people have the resources that they need to stay healthy and alive, to prevent the spread of, bloodborne pathogens and disease, to prevent overdose, abscesses, endocarditis, like all these different things that are wrapped into certain ways of using drugs. So for me, it is radical love and acceptance, meeting people where they're at. I don't need someone to be a smoking drug user versus an injection drug user for them to get the same exact level of care, treatment, supplies, whatever. I don't need someone's drug use or recovery to mirror abstinence fully. I just want to provide whatever resources I can to help just keep them alive and safe. And in today's day of the overdose crisis, I don't really think we can afford the shame route anymore. With the rate of overdose deaths, even in our community, we were the second highest per capita of fentanyl related overdose deaths in the state of California in 2020. And we're a small community, and we felt that really, really big. And we've seen what happens when places start distributing naloxone and doing drug education that's based in reality and really talks about these risks and resources. So we see the overdoses decline, and we see linkage to care improve, and we see trust build when you treat people with that dignity and respect.
It's amazing what love will do.
It is. Sorry, that was such a tangent, but
No, that was not a tangent. That was,
what we're talking
don't
about
say
here.
sorry.
yeah, sorry.
It was
It's
great
wonderful.
because harm reduction is about saving lives and loving people. And so I know that we've seen over the years, people will majorly go do stigma, like you mentioned, with pregnancy. For years, people be like, if you give condoms, there are parts in the U.S., if you give condoms, they will have sex. And it's like,
They
no,
will have sex.
they will have sex no matter what.
No matter
So
what.
We're
it's
back to
very
that head in
similar.
the
Like,
sand.
come on. Yeah, we just want people to be safe, whatever it is they're going to do, because they're going to do what they're going to do. So it's like, it's all about like, okay, well, just want everybody to be safe and be okay.
Yeah.
And like you said, there's no set thing of like, oh, you have to be doing this, or you can't be using this to be able to get help, or you can't get housing because you can't be doing that. I will see things in the community. We're just bringing out these, those people, for homeless or mental health or substance use. And it's like, no, it's none of those things. Things are happening. People are struggling. So,
I have a question. As a mom that's going through the Al-Anon program and trying to learn, boundaries and is there a line between harmful or, sorry, what is it referred to?
Harm
Harm
reduction.
reduction, not harmful reduction. Harm reduction and enabling.
Yeah. So one of the things I was going to say too, right before you asked the question, was a caveat of, especially when I'm talking about stigma and stuff, and we're talking about dismantling it in relationships with people who use drugs, and you're talking about offering compassion to people that are using, and offering, person first language and all these things. I think it's really important to also acknowledge the extreme chaotic drug use can affect so many more people than just the person that is using drugs. It can affect families, it can affect friends, all of these relationships. So the expectation, I think, when people hear about harm reduction, they think, well, I'm just supposed to be okay with someone stealing from me or lying to me or like continuing to use drugs. And it's like, no one's asking anyone to be okay with those things. Those things aren't okay. And it's horrible that that is a byproduct of more chaotic substance use. Within harm reduction, like boundaries are so important. When I talk about stigma and I say, yeah, let's do these things on the left, compassionate care, person first language, a lot of the times people are like, well, how am I supposed to do that when I've been lied to and cheated and stolen from and my heart has been ripped out from my family member? And it's like, okay, maybe what harm reduction can be in that situation is passing the torch to someone else within the family that can help for that day. Or it can look like, if I don't feel safe with my daughter, this was me, being in my house overnight, staying here for prolonged days, what can we do that is compassionate within the level of our boundaries? So that can look like they can be here during the day while I'm here to eat a meal. They can be here to take a nap on the couch in the middle of the day when I can watch. And that is a huge way to show compassion and do those things while you still have your boundary. Because I do think that boundaries are also very important to all of recovery. Sure. It's like if I let someone walk all over me, that's not doing any good for me or them. So I think it's tricky, and I think it takes a village in a way, and that's where it's kind of unrealistic to expect that one person is going to be able to handle navigating recovery that's chaotic, with just themselves and limited resources. Like we need sometimes MAT, we need, counselors, we need friends and family that are willing to help. We need harm reduction resources. Maybe call on the harm reduction group and be like, hey, I'm struggling with this. What can y'all do to support? Do you have MAT that my son won't go into a program? Is there telehealth? Like, I think it just takes a little bit more of a village, and those boundaries are so important to maintaining it. I don't know if that really answered it. I kind of went off.
It did.
Yeah.
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 It did.
I think one of the things that Annie was mentioning is a common concern with harm reduction, right? Like, is harm reduction enabling someone? And I think that you so eloquently put it that the answer is no, it's not enabling a situation. It is still allowing for you as a mother to draw your own boundaries. And if your own boundaries is there's no substance use in this house, that can still be implemented, and harm reduction principles can still be implemented.
Yes.
There's a way to do both. Harm reduction does not enable. Harm reduction does exactly what it says. That's it. It just reduces the harms while it's occurring.
It's so true, because harm reduction is information. So sometimes it can feel like giving someone information, because I've given patients, I'm like, I am not telling you to go use. I'm not saying, if your goal is not, but I'm like, you need to know how to be safe. Should you do that? I mean, how many kids, please do not order things off of the internet and use them. You know what I mean?
Yeah.
My God.
Yeah, right. You don't know
Thing
what
number
you're
one, do not, no, we know. But it can feel, like you said, like, well, what's the thing? But to have the information, to have that education, somebody can make a choice, because I'd rather somebody have the information. People slip, and that's also a big thing. It just totally was making me think of Gabor Mate. So good, because he talked about, part of substance use disorder is also relapse, at times. And so for a person, a lot of times, because it's not just the person struggling, it's their family, it's their job, it's their friends. If they slip, I've had folks talk to me, they're like, I don't want to tell my family. I can't tell my family. They're counting on me that finally it's stuck. So they feel even more ashamed than before, because they're letting people down. Right. And that's the part, with, you totally get that with Al-Anon too, but then it becomes not just them beating themselves up. They're so worried about letting people down that love them, that they are getting love maybe, or their community. So it just kind of makes it hard. But yeah, harm reduction is harm reduction,
Right. People often confuse it with some form of enabling, but I mean, there's clear studies that have shown, look, the rates of overdose decrease, the rates of septic arthritis and endocarditis and HIV transmission and hepatitis C transmission, all get reduced. And those are good things. Those are good things to society as a whole. even if that person is still out there, you know, in the midst of their substance use disorder and still using drugs, you know, at least there's some other things that are positive, you know, that are coming from it. So it's a start.
Yeah.
It's not an absolution, but it's a start. You know, ultimately, would we love to see people, you know, go into remission with their substance use disorder and get treatment however many times it takes, 1, 2, 3, 4 or more, until they absolutely get it and completely put their substance use disorder in remission? Absolutely. Absolutely, those are still goals.
Right.
But in the meantime, let's reduce the harm associated with it. I think that's important.
That's huge because sometimes I'll talk with people and they're like, well, I don't want to be on Suboxone. Matt, you mentioned medically assisted treatment, Suboxone, could be
Sublocade.
methadone. Yeah, Sublocade, which is, you know, Suboxone. And it's so interesting because I'm like, nobody says boo if somebody is diabetic and they need
Right.
insulin. And I'm like, we would never, ever, ever suggest to someone,
Yeah.
how long are you going to be on that? You know, kind of thing. I'm like, oh my God. And then I always will tell people, I'm like, because that moral flaw, character flaw
Right.
or whatever, like, oh, if you really wanted it, you could. It's like, no, that is literally not a real thing. And I always think of me with sugar, with white sugar.
Right.
You know, I think I first went off, I was raised total health food, you know, but I'm junk food too. And I remember getting off white sugar at 24. And by night 4, I was in fetal position. And I mean, I still ate fruit and honey and stuff, but I remember thinking, oh my God, like I was so uncomfortable. And I thought, I can only imagine nicotine and heroin at the time, because now I'm
Right.
in my 50s. And so I think sometimes just to show people like, oh, and I was like, good Lord, for me to even this time to get off candy cookie ice cream, I go, it takes weeks to do it. And I said, so here we have somebody presenting, maybe at the hospital, maybe somewhere else, like, well, you know, you should get off of that. I'm like, oh no, it takes a while to
Right.
get a mindset. There have been folks who come in and they're like, I'm in month 6. And they're like, I'm just to the point now because they had to wrap their head around they were going to get off of opiates. And it took that long for them to get ready. And I'm like, yeah, like you can't, you know, in the meantime, I'm like, we cannot just expect anyone to just stop, you know, or a person who doesn't use their insulin and is still drinking, you know, or all their soda pop or whatever. And it's just a respect thing.
Yeah,
It's a respect thing all the way around.
absolutely.
You know, and holding space for somebody who's struggling,
that's right.
whatever it is.
And the opposite of respect is shame.
Yeah.
And so I keep hearing the repeating theme of shame. You know, the shame that comes, the shame that's imposed upon, the shame that's threatened. If you should find yourself potentially relapsing, shame, right? And it's like, I think it's so important for the people listening to know that there's no room for shame in this, because this is all of us, and it impacts all of us. And as long as we go into this is a morally flawed person mindset, we're just injecting shame into this, and there's no room for that right here. And that's, I think, is really helpful to you talk about wrapping your mind around something, wrap your mind around that there's no shame in being a diabetic and needing insulin. There's no shame in having substance use disorder and needing help, you know. Now, you mentioned the hospital a little bit. If somebody were to be listening to this or know somebody that could maybe benefit from coming into the hospital, I would imagine there's also feelings of reluctance and maybe what is this going to be like?
Yeah.
How am I going to be treated?
Yeah.
What's going to happen to me? What's going to be done to me?
Yeah.
If somebody were to find themselves coming into the ED at our hospital, into the emergency department, what can they anticipate? What's kind of the normal course of treatment that?
Nowadays, we are one of our Sierra Nevada Memorial is one of almost 300 hospitals throughout California that is has a bridge program. So I think Nathan Clayton and Shelley Leal started that in 2019. And at first, I will kind of circle back around. Correct me if I don't, but terrible storyline. But in the beginning, it was difficult because people really talked a lot about, and still have times where they feel that there's stigma coming in. But when the ability for doctors to write for pain meds, really the pendulum went woof. And all these people were like, oh my God, I have chronic pain. I have all kinds of stuff. Now I'm called an addict. What are you talking about? And we're told to do, mindfulness and yoga and meditate.
Yeah,
I'm
just
like,
breathe,
right? Just breathe. I'm like, oh my God. So then a lot of folks would go and ended up using street drugs
Sure.
because they couldn't get what they needed. So that does not happen anymore. Somebody can come in 24/7 and they're really savvy. They're not looking at arrest warrants. They're not looking for other things. Somebody could have a stimulant use disorder and need to come in for opiate use disorder and get treatment for opiate use disorder. We're not like, oh, you're still using this over here. We can't treat you. So they can just check in like everybody else and say, hey, I'm here for Suboxone, or I'm in withdrawal. I'm feeling really sick. I don't want to do that. Or even I'm not in withdrawal, but I would like some Suboxone so that I could do a home start. They will do that 24/7. They don't have to call or connect with me or anybody else. Yeah.
And how does that get maintained? Because somebody has to prescribe Suboxone.
Yeah. So to get maintained, I mean, we do have some people that will come back just with their schedules and stuff, but Dr. Kevin Kuhn started Nepali treatment, which is super low barrier, which is amazing. He can do a phone visit over the phone. I mean, it could be FaceTime, it could just be phone, Zoom, whatever. Same day to get people, for folks who just want to get a prescription because they work and they're like, I do not have time, to go to outpatient. There are outpatient programs as well. There are places that you don't even have to be in outpatient, but you can go to a brick and mortar to get that prescription going on.
So does that mean someone comes into the ER, right? They're feeling dope sick,
Yes.
or something like that. They're like, look, I need some Suboxone.
Yeah.
And they can come in and get Suboxone in the ER
Yeah.
right then and there. Then they leave.
They have a
and-
prescription that they've called in for them, a bridge.
Right, so they have a bridge, but then that bridge needs to be maintained after there's a bridge. So they need to find another provider to
Yep.
continue that Suboxone prescription sort of indefinitely.
Yes.
Is that where they call Dr. Kuhn? Or
They can. So I get referrals. Bethany gets referrals at Yuba Harm Reduction. So, there's Aegis. There's Aegis, Chapaday, Western Sierra, Kevin. There's Granite Wellness, like within town. Where else? I think
about
that's
it.
the ones in town. Then there's Bright Heart Health online. There's letsrecover.com online. There's so much stuff out there that they can keep that prescription going. For some folks, like you said, with chaotic use, it can be difficult, like stop start. It can be difficult to go to outpatient program, whether you do inpatient treatment, outpatient. The groups are during the day. The stuff is during the day. But yes, so I get all kinds of different referrals. And a lot of times I see now, because I read all the doc notes whenever somebody comes in, I'll see that the providers out of the ER too are even referring folks. Like, this is, here's the number, here's the name where they can follow up, or they can connect with me. But yeah. So there is stuff for them to keep going on. I have to say the low barrier really is one of the best. It's because it's low barrier.
So we went through Kevin Kuhn with my son.
Yeah.
When he came to us and admitted to his opiate use and said that he wanted to get clean. And he started to go into withdrawals, and I was calling around frantically and trying to, what's the next step. And I feel decently educated on it. Felt decently educated on it. I no longer feel decently educated. It was an eye opener. I've transported many patients that have said, I want to go to the ER to get clean. And I've also heard many stories from people that say, I'm going to go to the ER. I'm going to tell them I want to get clean. I'm going to get, might be a benzo for my alcohol addiction or get started on Suboxone. I want to go into an inpatient treatment center and there's none available for me.
That's true.
And I look at the amount of support that I had to give my connections in this community, which played a huge part in it. If my son had not had those things, he would be using right now.
Yeah.
And so I wonder what else we can do in our community for these people that don't have that support system.
That's
You know, my son had a huge advantage in the fact that I know Kevin Kuhn personally. I heard that he was running this clinic. I had no idea prior to that day, and had his cell phone number in my phone. You know, that's a huge advantage.
Massive.
These people that I am, giving Narcan to and keeping alive and then taking them to the ER, like, that does not exist for them. And I actually started carrying cards from the detox center that my son went to in Southern California around in the ambulance with me to hand to these people, because the ER is fantastic at what they do, and they do the best that they can in that time period. But like you said, there's those next steps that come, and the mind of an active addict, it doesn't make sense of the world the way the rest of us do. They can't follow steps. So I'm really, that is my biggest concern, and especially, it's always been a concern of mine, but now, having been through what we've been through recently, I just feel so much for these people, and I feel like it's so important to catch them in that moment where they say, I want to get clean. And really, and get them there and make that happen for them, or, give them everything we can to help them help.
Yeah, I hear you. I think this is something that we've talked about this, like it's such a access, right? It can be like transportation barriers or no support system or fiscal barriers.
No housing.
No housing. And so I think that, triangulating different forms of care, like our street outreach team has formed relationships with a lot of people that are unhoused and using drugs. And when we launched our telehealth MAT program, they already knew us and trusted us. And so that's been a really great way as far as offering some resources to people that are familiar with who we are, that we're not going to be judgmental and such, but then also that we are able to do telehealth with them in the field right then, have a case manager that can drive them to their appointments. We offer transportation to Marysville to start methadone, transportation to the local Aegis, transportation to SNMH. We did a focus group a couple years ago, and we were identifying barriers, a paid focus group, barriers to various levels of systems of care and healthcare within Nevada County. And one of the biggest ones was what you're speaking to, is like, I don't know where to start. I don't know how to start. I think of myself as like a pretty stable person. When I have to navigate healthcare systems, it is a whole day affair sometimes.
Yes.
It is jumping through hoops. I have to know the lingo. A lot of the time I'm pulling on connections that I have from doing this work in the county. If I was living outside and have co-occurring substance use and mental health issues, my ability to navigate our systems of care would be, it's cheaper and easier to keep using fentanyl. It's like, I hear that from people often of like, I have to drive 45 minutes to Marysville and wait 4 hours for an intake. I'm just going to keep using because I don't have a car. I don't have money. I don't have that time. So I think that that's such a huge issue, is like, how can we make this more accessible to people?
It's hard with our treatment because, I mean, and you guys have private insurance, but so for a lot of folks in our county with Medi-Cal, like, fortunately, and actually for our county, for folks that are on Medi-Cal, because there are no detox beds, or if there are, there's so few and that they're full. So sometimes it's like, oh, there's a week, or maybe they can get them in the next week, or there's a 3 to 4 to 5 week wait to get somebody inside. Our county actually is really good about, they have substance use case managers who are in recovery and have been in for some time that can give rides and they're lovely. We're so fortunate because like the county next to us, they don't have that, and that's kind of how I started at the hospital as a navigator, just straight up patient navigation, to reduce, readmissions for anyone who's been hospitalized. And it is just, we have another one in our office. She's part-time, but we literally every agency could have just navigators trying to help folks because that don't have that tolerance to just be sitting there on the phone. That's a minute phone that's going to die in 20 minutes and 21 minutes, and they never talk to anyone. you know, and so it's hard. We see those, you guys are bringing them in, and then we see them in the ER. A lot of folks know, but they can't wait the 2 weeks, you know, or they don't have housing. And also there's just so much access out in the community from people who know each other, and it makes it hard, even what you can get in the lobby at treatment. And so that even goes bigger to be like, what is going on with so much of our economies, not just in our area. We're rural, but we got a lot of progressive, we got a lot of working class, we have everybody, but so many areas. So you're going to not use, then what? Now you don't have that community. If you're not using, then you go to this community. Well, you don't have housing. Maybe there's not work. There are just so many other things. It's not just the focus that goes back to stigma of the usage. What about all the rest of the stuff too? And that's what makes it hard. Because what can we do with that?
You know, we're talking about some of these barriers, and these barriers are profound. I experience it routinely. You know, if someone really, really has made a decision in their life, like that's it, I'm done, I want to get clean. It's not that simple. It just simply isn't, you know. Let's say they call a local place like Granite Wellness Center, hey, I need to go into detox, I'm ready, let's go. And the first question they're going to hear is, well, what's your insurance? You know, are you private pay? I bet they'll find a bed for them if they're private pay. I bet they'll even find a bed for
They
them
won't.
if they're commercial.
They won't.
Well, they're understaffed right now. That's part of, you guys came in at a time of a.
but you understand my perspective.
Yes,
like
for
there
sure.
is a place where you can
Already
find
they're
with your
turning them
private
away
pay.
with the U-turn.
Yeah.
Yeah.
Places like
And
that
then
and
your
others.
Medi-Cal, right?
Right.
So there's a certain number of Medi-Cal beds. There's a
Yep.
long wait list for Medi-Cal,
Yep.
yet someone is ready at this moment.
Yes.
Because, right, they need to be emotionally ready, spiritual ready, physically ready. You know, they need these things, and it happens on this day. And they can't get in that day. That spiritual readiness or that physical readiness or that emotional readiness can regress and wax and wane, you know, within a person. That's part of the addiction process.
leads
No,
to
totally, because they
helplessness and-
present, and I've seen, to be like, I need a detox, or they've been referred by an agency, especially from people who do not understand. We are a small county. They need a detox bed. I'm like, we don't have that. They're like, what? I'm like, we don't have those here. But I heard that someone did, and I'm like, yes, depending on medical acuity, there are folks that will detox inside the hospital, but a lot of folks will do a detox with medication for alcohol, maybe opiates, but then there's that wait time. And then, like you said, and it just kind of waxes and wanes, or the feeling of defeat. I finally got ready, and then someone goes, so sorry, we can't help you,
Yeah,
but
we're
here
not
is a
ready.
prescription, which is a great thing, because some places they don't get a prescription, but still, and it's like, how many, you know, peer support right at the ready, how many navigators could we have?
I know for me, and I can speak from personal experience here, the only way, and I've had a couple of relapses in my recovery, the only way that I've ever been able to get clean and stay clean and put any substantial amount of time together is to go into a protected environment like a detox, sit there under a controlled environment, and then from there transition to a long-term inpatient treatment facility, again in a protected environment where I can start to gain the tools while I am, you know, recovering from a significant detox. And those are the ways to achieve, in my perspective, success for long-term recovery. And we have these barriers where people can't go in and do that, at least not immediately. You know, there's, like you mentioned, there's weeks and weeks and weeks of wait. We need to implement a system where when someone says, I'm ready right now, today,
Right.
that they can be admitted into a program that day.
So
Yeah.
funding.
Yeah.
So
You know what I
this-
mean? It's funding, because the more, if we had more beds, we had more support, then people could avail that.
That's
Well,
what I
this
was
goes back to Dr.
That's what I was
Berry's.
talking about when I
Yeah.
first started with the research dollars.
Yeah.
We need more.
Yeah.
If we had the same money that we
Yes.
had for breast cancer research,
Yeah.
for addiction and recovery,
Absolutely.
a ton more people would
Sure.
be clean and in recovery right now.
Yeah.
Yeah, this is
And it all
a-
goes back to destigmatizing it
Yeah.
because it's not talked about. It's not, you know, I know that I lived in fear of sharing my son's and our family story with my coworkers and
Right.
my community,
There's
the
that shame
hospital,
again. Yeah.
and I had to call 911 when he was detoxing and had a
Right.
seizure, and here shows up all my coworkers,
Right.
and it was like, here we are.
Yeah.
And the amount of support that I've gotten since I opened up has
Yeah.
been heartwarming and amazing.
Yeah.
But that took me a couple years to
Right.
get to that point where I could share that.
Well,
Yeah.
and I want to, that is such a thing of just trauma in general, right?
Yeah.
Whether it's substance use, that is so something
Yeah.
where with childhood sexual, trauma, where somebody you finally say, and then you realize, oh my God,
Right.
there's all these other people. And
Yeah.
just no one is talking about intergenerational trauma and then
Yeah.
the healing and the healing of the collective for
That's
that,
right.
whether it's a little community or bigger.
Yeah. we
Well,
have to
we're
start
up
talking.
against the clock with our talk, but I'm telling you, we should have like a 4-hour podcast because this is
Monthly.
so terrific being able to unpack some of this stuff with you guys. Can we do a little bit of a speed round right now? Now we just heard funding, but if I could ask you, for the people listening, for people in our community, for just people at large, in 1 or 2 words, what can people do to help?
Acknowledge.
Good.
Carry naloxone. Know how to use naloxone to reverse an opioid overdose.
Right on.
I think it's part of the destigmatization. They can educate themselves.
Good.
And talk about it with
Mhm.
others.
Yeah.
Put it out in the community.
Good.
That it's all of us. It's we. It's
It is.
we.
It's all.
we.
It's us.
And,
We're in this
and
together.
love the addicts.
Mhm.
Every one of them is someone's son, daughter, father, mother, brother,
That's right.
sister.
That's right.
They're us.
That's right.
And we all deserve second chances and sometimes third and fourth chances. And please don't judge me on the mistakes that I've made in my life because we've all made them.
Oh, of
Judge me
course.
on how I've responded to those mistakes
Mhm.
because that's the person I am today.
Yes,
That's right.
absolutely.
Well, thank you all for being here. It's a heavy topic, but there's so much love in this circle right now as we talk about the things that we face. And so, blessings on the work that you do, and thank you for the conversation.
Thank you.
Thanks for having us.